Welcome everyone. My PhD thesis is Imbalance in vascular reactivity between women and men. I'm Ádám. I work at the Department of Restorative Dentistry and Endodontics. My supervisors are János Vág and Beáta Kerémi. My SMS was Petrana, now Esther, and I work with Gergely Agócs. My vision is improving the quality of female patients with cardiovascular and periodontal diseases through providing evidence-based data for personalized care. My two projects are the sex differences in macro and microvascular reactivity, a systematic review and meta-analysis, and comparing post-occlusive reactive hyperemia on the finger between healthy and periodontitis patients, a prospective clinical study. Let's start with the first one. Cardiovascular diseases are the leading cause of death globally for both women and men. The endothelium have essential roles in maintaining the cardiovascular health, for example, maintaining vascular tone, regulating angiogenesis, and so on. The age-adjusted CVD death rates and incidences are higher in men than in women, and one possible explanation behind this could be that the endothelium is target for estrogen, which modulates its functions. Despite these differences, however, women have been traditionally underrepresented or even excluded from clinical trials. When we want to assess cardiovascular health, the post-occlusive reactive hyperemia and its tests come in handy, which is a complex phenomenon that can be utilized both on macro and microcirculation in a non-invasive way. However, to date, the influence of sex on pore measurements remains uncertain. So our aim is to compare the pore between healthy females and males. Our clinical question: is there a difference in pore between healthy females and males? Based around the PFO framework, where P1 and 2 is pore on the brachial artery and on the skin, F1 and 2 are healthy females and males. Our primary outcome is change in artery diameter or flow-mediated dilation. The secondary outcomes are base artery diameter, the change in blood flow, the wall shear rate, and the time to peak. And our hypothesis is that women have higher pore than men. The search was carried out in 3 big databases, and you can see the attached search key here. The initial search yielded more than 18,000 records, and after the selection process, we were left with 94 eligible articles. The univariable analysis of the brachial artery results are done, however, their multivariable analysis and the analysis of the skin results are still ongoing. Our primary outcome was the mean relative artery diameter change or flow-mediated dilation. In this analysis, 48 articles were selected with more than 2,300 participants, and of them, 45% were women. The forest plot is divided in 2 parts. On the left, you can see the results or the data for the female, and on the right, the data for the male. The overall mean dilation was 9.3%, and if we look into the sexes separately, women had a mean dilation about 10.4%, and males had a mean dilation of about 8.3%, and we can say that there is a significant difference between the 2 sexes. On this slide, you can see the scatter plots representing the flow-mediated dilations in relation to age and BMI, and we can say that both predictors have a significant effect on the outcome. The first secondary outcome is the mean baseline artery diameter. In this analysis, 43 articles were selected with more than 2,000 patients, and only 43% of the participants were women. The mean baseline artery diameter for the whole population was 3.57 millimeters, and 3.17 for females, and almost 9 millimeters for the males. This is not a big surprise, but we wanted to carry out this analysis as well, as we are using this outcome as a predictor for the other outcomes in the multivariable analysis. The next outcome is relative blood flow change. In this analysis, 13 articles were selected, and 50% of the participants were women. Both sexes had a blood flow increase of about 580%, so there is no difference between the sexes in this regard. The next outcome is the mean wall shear rate area under the curve. This outcome is basically the physical stimulus for the arterial dilation. Both sexes had a high wall shear rate, and there is no significant difference between the sexes. However, females tend to have a higher shear generated during the hyperemic period. And the last outcome is mean time to peak, the time it takes to reach the peak dilation. In this analysis, only 10 articles were selected, and only 34% of the participants were women. There is no statistically significant difference between the sexes, but females tend to reach this dilation faster. The strengths and limitations of our study are the following. There is a huge number of studies and participants included in the analysis from multiple countries, and all of them were healthy and non-smokers. However, big limitation of our study that the post-occlusive reactive hyperemia tests are not well standardized. For conclusion, we could say that the male gender has a negative effect on the extent of dilation, and this implies that the sexes are strongly suggested to be separated for clinical trials, more exactly cardiovascular clinical trials, and this might have an impact on personalized medicine as well. Here you can see the status of our manuscript writing. As we are still waiting for more results, we couldn't progress more with the writing. Next, let's talk about my second project, which is comparing post-occlusive reactive hyperemia on the finger between healthy and periodontitis patients. Endothelial cells have essential roles in maintaining cardiovascular health. The post-occlusive reactive hyperemia test can be carried out on both macro and microvascular levels in a non-invasive way, and the test is a marker for endothelial health, for endothelial function. Periodontitis is a destructive inflammatory disease of the mouth, which is an independent risk factor for cardiovascular diseases through impairing endothelial function. Our aim is to compare the pore of the finger pulp between healthy and patients with periodontitis. Our question is that could the periodontal inflammation lead to changes in focal microcirculation? Based around the PFO framework, where P is pore test on the finger, F1 is gingival status, healthy or periodontitis, F2 is cardiovascular health, F3 is smoking status, and the outcome is change in blood flow in laser speckle perfusion units, which is the arbitrary unit of the system which we are planning to use in this study. Our hypothesis is that hyperemia is smaller in the focal area in periodontitis. For implication, we could say that the periodontal disease and its treatment affects the systemic health. For earlier clinical studies, I'm showing you two. On the left side, you can see that severe periodontitis significantly impairs the flow-mediated dilation in the brachial artery. And on the right, you can see the laser speckle image of the hands and the various diseases that come with endothelial impairment. Highly impairs the post-occlusive reactive hyperemia. So these were currently the two studies that I'm working on, and I plan to submit the first one this March. To know is to know that you know nothing. That is the meaning of true knowledge. Thank you for your attention.
You saw us some nice forest plots, and I'd like to know if you have any reason for your high heterogeneity as it is on the large forest plot where the female and, yeah.
This one or the previous one?
Yes, this one, because it's quite high. Did you find a reason behind it?
Well, First of all, these reactive hyperemia tests were not well standardized. There was a guideline in 2019 that establishes basic rules for this. However, there are many articles before this date. And as we are using a wide population, there is, of course, differences in, for example, the race of the patients. However, we wanted to standardize this as good as we could because we were using a small age range and all of the patients were healthy. So unfortunately, despite our efforts to standardize it, it couldn't be done better.
Is there a strong causal relationship between gingival diseases and arterial diseases? That is, if you treat the gingival disease, would it heal the arterial disease?
Thank you for your question. It depends on the causality because in severe periodontitis there could be a bacterial inflammation that spreads throughout the cardiovascular system. And there is evidence that in the cardiovascular plaques, some periodontopathogen bacteria could be found, and of course, we cannot remove these bacteria from the plaques without treatment. However, if we only look into the endothelial dysfunction, this bacteremia, of course, if we reduce the bacterial numbers with the treatment, this endothelial dysfunction eases a little and goes back almost to the normal levels. So yeah, our treatments work in this regard as well.
These studies were done all in premenopausal women, right?
Yes.
If you are looking at the postmenopausal, then these differences are disappearing between male and female, or still there is for a while a difference?
Yes. Well, basically with the menopausal transition, these differences, well, not only the differences, but this whole flow-mediated dilation drops with age. And after the menopausal transition, the dropping of this marker in women is so much faster than the male. It may even be lower than in the males with time.